Okay, vielen Dank für die Anführung. My presentation today will be about the second primary orbital malignancies in USA, and this study started from 1973. I would like to declare no conflict of interest. As you all know, the orbit is not just a bony cone that is 30 cubic centimeters in volume, but it contains multiple complex structures, veins, nerves, and glands, skin, and of course the eye. From our previous studies, we have found that lymphomas represent the most common orbital malignancy, especially in the age group above 50. On the other side, rhabdomyosarcomas and soft tissue tumors represent the most common orbital tumors, this is in the age group below 19. And on the other side, rhabdomyosarcoma had the highest survival in USA with 93%, followed by lymphomas, then melanomas and carcinomas. And we have shown also in one of our last publications that there is increased incidence, there is an increasing trend over time in the incidence of orbital tumors, and this is led by the increase in incidence of lymphomas. Also you know that there is 20-fold risk in the incidence of rhabdomyosarcoma and osteosarcoma after hereditary retinoblastoma. So we asked ourselves, is the presence of a previous tumor also affecting the incidence of elsewhere in the body, affecting the presence of or the incidence of orbital tumors, future orbital tumors? And at the same time, we would like to ask how often we should see them in our clinics. So we collected data from the Surveillance Epidemiology and End Results Program, SEER program, and this represents this 9 version, which contains 9 cancer registries in the US that represent about 10% of the US population. And you can ask me later, why not Germany? And we have collected the data about the orbit and the eye, because sometimes the tumors, there is overlapping tumors between the eye and the orbit, and we would like to compare them also. And we have used the International Classification of Diseases, Oncology 3, topographic and histological classification, and we have used also the IAC grouping to group the tumors. And because of the SEER data is anonymized, the study was exempted from the IRP. And as a statistical method, we have used the standardized incidence ratios. And to calculate the standardized incidence ratios, we calculate how much of the patients that had a first primary have shown a second primary in the orbit. Then we calculated how often the orbital tumors in general are presented, and we divide the observed over the expected to know the standardized incidence ratios. And we have found from 3,500,000 patients, around 1,317 orbital cancer patients. So it is around less than 1%, one in 1,000. And we have seen that the male to female ratio is about 1 to 1. And the age at malignancy, we have found that around 50% of the patients are between 55 and 72. And the race is almost white in 93% of the cases. Of the site of the first malignancy, it was 16% breast, 22% prostate, and this should be similar to the distribution of these tumors in the general population. And we found that these absolute numbers should not be helpful for us because, so these numbers will be the most patients that we see in our clinics if they have these tumors. And the site of the second malignancies were mostly in the eye. Most of them, around 490 patients, were melanomas, and the other were distributed between eyelid, conjunctiva, and orbit. So these are the important numbers. So how much risk is involved after the first primary? And we have found increased risk of eyelid tumors, and most of them, or the significant statistics showed that non-Hodgkin lymphoma, melanoma, and skin carcinomas are really higher than the normal population. And also the total in conjunctiva was somehow significantly, but not that high. And also non-Hodgkin lymphoma in the lacrimal gland, which was for us interesting. And also by site, we have found that from orbital adnexa, osteosarcoma showed very high significant risk, but low number of patients. So this is the number of patients, but this number represents a higher incidence than normal population. So also here in the tumors in the eye, and by histology, we have found that patients that developed leukemia before was more prone to develop leukemias also in the eye, which is this is an interesting question. Which leukemias can happen in the eye, and this was very high, but also low number of patients. Also osteosarcoma, CNS tumors in patients that had primary also CNS tumors, germ cell tumors in those who had also CNS tumors, and some other miscellaneous, which is including orbit and osteosarcoma. And by comparing the survival, we have found that the primary orbital tumors showed a less primary orbital tumors showed a higher survival than the second primary orbital tumors, and this difference was significant. And comparing to the other secondary tumors elsewhere in the body, we have found that orbital tumors showed a higher survival than the other elsewhere in the body, second tumors. And we have, by comparing and connecting the literature, we have found that there are increased or shared mutations between these tumors. We have here plotted the tumors and the shared mutations, and we have found that the most one is, as you know, TP53, which is included in some syndromes like Lipomini syndrome. So this study can represent a future perspective for markers development after first tumor that can guide us to calculate the prognosis. And also, these tumors can share the same pathogenesis, so we may include them in studying the influence of the targeting therapy on them also. And the take-home messages, so please ask in details about the previous malignancies that this patient had. It may guide you through the diagnosis of the current case. And you may be the one who diagnosed the second tumor, so take care. And I would like to thank my colleagues, especially Anas Saad, who did the statistical analysis of this study, and also my previous cooperators and the editor. Thank you.
Yes, thank you very much. Jetzt muss ich aber das Publikum mal ein bisschen animieren, Fragen zu stellen. Möchte jemand die erste Frage stellen? Natürlich fragen wir, of course we ask, why did you use an American cohort for your studies? You just encouraged us to do so.
So the German cancer registry started in 1970s also, but to mature it needed some time. So it started in Saarland, and then as you see I didn't present this point here, but the meantime between the first primary and the second primary was around 15 years, and to follow this we need a huge population and long follow-up time. And the complete cancer registry we can get here in Germany is starting from 2000s. And this was not suitable for our study, so we decided to shift to the SEER study, and also we have collaborated with the German Cancer Registry to develop one of the studies about the first primaries.
Mm-hmm. And which cohort was the basis for your comparison, for the risk analysis?
For the comparison to the population. So these cancer registries collect the data from also the population they are living in, and we have used the same cohorts from this population from US registries to compare the population to the cancer registry itself.
All right.
In Germany, you often have the problem that if they're doing controls from the internal department, they do MRIs without scanning of the head. You know, they do MRI scans, but they don't include the head MRI scan. So one of your data or consequences of your data would be that perhaps you have to tell the internal medicine or the doctors that they're always doing the scans of the orbit as well if they do control, isn't it?
Yes, I would say,
especially in non-Hodgkin.
Yeah, I would say at least refer the patients to the ophthalmologist, because he may also have other intraocular tumors, or even if it is leukemia, which is a systemic tumor, a systemic malignancy, but it also can manifest in the eye. So even the patients that had acute leukemias or chronic leukemias, their first either second tumor or their recurrence can be in the eye. So it can be coloroma, it can be represented in intraocular tumor, but it should be also included in the screening.
Yes. So thank you very much for your talk, and I hand over now to Professor Bisch.
Wir würden gerne den nächsten Vortrag, wenn keine weiteren Fragen sind, ankündigen.